Thank you for that great introduction. And I'm happy to be here and to be able to share some of my work with you. I'm sharing my screen. Yeah, I hope that worked. And I will try to defend in this talk my provoking title of why I think that currently most published prediction models are not able to support treatment decisions. This is based on joint work with a lot of collaborators, which I mentioned here at the bottom of the slide. Okay, so I hope we agree that we often encounter people who have unrealistic expectation of prediction models. Here's a quote from the current one of the current Horizon calls that states that they envision in their call, in their projects, healthcare professionals utilizing AI tools to assess and predict the risk or progression of diseases, and hence, they say, citizens will benefit from improved health outcomes. So the picture that is sort of being sketched here looks like this. I would be able to take my sick mother or grandmother to a clinical prediction model, and she would come out alive and kicking, so to say. This is, I think, very obviously not a shared thought among us, because we all know prediction models are not interventions. So on their own, they will not be able to cure or to protect a patient. But I do think we have expectations that prediction models can help improve health in general. So of course, what prediction models can do is they can discriminate between patients or persons with high risk of a disease or a bad outcome or progression of disease, and those with low risk. So maybe the woman on the right side of the slide. And this information can be very useful for several reasons. So for first reason to mention is that we can counsel patients. We can inform them on how we expect their future will look like based on prediction models. And this information can help them to prepare or to cope with certain situations. What we also use prediction models for is to make certain substrata, to make a certain selection of patients that we might want to target in a clinical trial to see if we can improve their health. And then we go on that sometimes we also want to use prediction models to inform individual treatment decisions, and also to maybe prioritize patients in case we have limited resources. And in general, we think that the high-risk patients would be more in need sort of treatments. So if we would think about both of these persons on the slide, maybe thinking about contracting COVID, we would expect maybe that we want to target trials maybe on the higher risk patients. We want to have more opportunity to sort of improve health, then we want often start out in higher risk groups. And maybe if these persons would have the choice to start a certain treatment that might also have side effects or which may be aggressive or burdensome or costly, then we also think maybe the risk-benefit trade-off that they have to make will be more in favor of treatment in high-risk patients. So we have several expectations of prediction models that they can help us in these directions. And the general trend in this expectation, I think, is that in some cases, the risk that we estimate may be so low that we may refrain from using a treatment. And if the risk is high, then we have more reasons or a bigger sort of trade-off component in order to start treatment. So up till here, I'm still quite sort of positive. I think in these directions, we hope that our prediction models can help us. But a big issue here is that these expectations are often left very implicit, sort of very vague. And in particular, we often omit to state what kind of risk we actually mean that is able to inform these kind of decisions. So if we talk about high risk or low risk patients in relation to treatment, what risk would inform our treatment then? Would that be the risk without ever being treated? The risk under the current standard treatment strategies, maybe the risk before being treated, or even something else? I think this is really an issue that we have not progressed good in. We often leave this unspecified. So we have an idea of high risk means more treatment, low risk, less treatment, but we don't say what risk we are actually thinking of in this context. And that's an issue I want to talk to you about. Okay, here's a bit of an outline of this talk. I will start by talking about prediction estimands that are described in a way that might help us to better make more explicit how our risks that we talk about relate to treatment. I will show a numerical example using data from kidney transplantation patients. I will give 2 examples of what we see happening in current practice, or what do we see being reported in medical literature. And in the end, in my conclusions, I would like to look back to you to these 4 aims, and sort of update our view on what prediction models can or cannot do in these 4 aspects of counseling patients: risk stratification for trials, of making individual treatment decisions, forming those, and in prioritizing patients. Okay, so our prediction estimate work has been mostly based on the addendum for clinical, ICH E9 addendum for clinical trials. So I understood that the last event of this group actually was based on a talk by Brennan Kayam, especially on this topic of estimands in clinical trials. So I hope most of you are familiar, but just to be very short, in this guideline, in this trials guideline, a lot of attention is given to intercurrent events, which are events happening after randomization and before the assessment of the outcome in patients. And the addendum gives clear rules and guidance in how to link your research question, so the treatment effect that is targeted in a trial, to your analysis, where you have to deal with these kind of intercurrent events like treatment switches, dropout, or maybe loss to follow-up, etc. So that is in the trial setting, and here we're going to map that. So we're going to use the framework in the prediction setting. In the trial setting, in this document, there have been 5 proposed strategies, they call it, how to deal with intercurrent events. And here we use 4 of those for the prediction setting. So those who are really into the estimate framework, you will not see an equivalent of the principal stratum strategy. That one we did not find a clear equivalent to the prediction setting for, but you will see the other 4. And this is the setting that I will consider. This is not a causal DAC, but a more like a state transition diagram from multi-state model literature. We assume that we start out event-free at some baseline time point where we measure baseline predictors, and we're interested in predicting the time until somebody experienced an event of interest, which is denoted by T. And somewhere after baseline and before that event of interest, patient might decide to start a treatment. And we denote by V the time from baseline till that treatment starts. So quite a simple framework. We want to predict risk based on baseline predictors, and we have some treatment post-baseline that might be initiated. Okay, let's look at the first strategy that we might take then when we're predicting risk based on these kind of data. And that's actually the most easy way to do it, and what I see also is the mostly used method to do it. And that is to just use an ignore treatment strategy. So just to say, okay, I know that some people started treatment somewhere along the line, but for now, I don't care about that. I'm only focusing on the event of interest. I want to target the probability of a person experiencing the event of interest before some time horizon, then I'm like 5-year risk, 10-year risk, or whatever, conditional on baseline covariance. An interpretation that I could give to such a estimate, such a target, is that I'm interested in the risk occurring before some T horizon, where some patients will and others will not start the treatment along the way. For example, this was used in the original calculation of the Q-risk3 risk calculator, which assesses cardiovascular risk in general population. The excluded patients using statins already at baseline, so they wanted a sort of a treatment-naive population, but treatment initiation, statin initiation after baseline was just allowed. So part of those will have started statins during the follow-up that was included in this risk calculator. The strategy makes sort of estimation life easy. It's quite straightforward. We could use any survival kind of model for T if we have censoring, or even a logistic model if we don't have censoring. There's nothing difficult to do there. But there is a big consequence of using treatment in this way. And that is stated here. If we are to use such a risk score in new patients, so if we want to apply our developed model to a real clinical setting, we have to assume that the decisions made for treatment in these new patients would be similar to those in the development data. Right? Otherwise, we will not have correctly specified our risks. So we have to assume that there will be no changes in who or when we are describing statins to patients. And that also implies that this strategy does not give us risk that can actually inform a different treatment choice. We wouldn't know actually for an individual patient whether in the development data they would or they would have not have initiated statins. So we also don't know how we should deviate from that strategy. That does not make this strategy unuseful. Of course, it can still be very useful. And in particular, I think it can be very useful for like background treatments, where you don't have the interest also to make a decision, but you just, okay, maybe we all use sometimes, I don't know, paracetamol or other kinds of supportive treatments. And we think it's good to estimate risks in presence of those treatments. But for the particular treatment here, so for instance, for statins, this kind of predictions cannot inform us whether or not somebody is in need of such a treatment, because we are, per definition, assuming it is used in the same way, in the same fashion as in the development data. Okay, let's look at another approach that we might take. What we could also do is we could also define treatment initiation as a component of the outcome, to use sort of a composite outcome. Then we are targeting the minimum of the two time periods, so the minimum of time to event and time to treatment. Again, interested in whether one of these events happens at least before the time horizon, conditional on baseline covariates. For example, this is often used in cardiovascular research, also where we might take together as a composite outcome different things that might happen, so for myocardial infarction, cardiovascular death, and then also invasive treatments like bypass surgery or maybe revascularization can be included in the definition of that composite outcome. Estimation is again quite straightforward here, which is targeting the minimum of these time points, and no particular complicated statistics is needed. But here again, we are assuming if we use these kind of risks in new patients, that their treatment strategies will be similar to those in the data that was used to develop this model. And again, this kind of risk can therefore not support treatment decisions that would be deviating from that strategy. It's again not unuseful. It is still useful to use these kind of risks in some cases, and in particular, I think this composite strategy can be very useful if you think that the treatment initiation is actually kind of proxy for the event. So if not having given bypass surgery would have led also to myocardial infarction, we could sort of equate these two events as both being an indicator of a bad outcome. Okay, let's look at the third one then. So this one in the E9 addendum is called the while treated actually. Well, here I'm changing that sort of to the while untreated. So a little adaptation, but the idea is the same, and that is that we are evaluating the risk in a time period where nothing has changed yet, and that is in the time period actually before a certain treatment occurred. And what we are then estimating, what we're targeting, is actually a quantity known from competing risk analysis, is the cumulative incidence of the event of interest. So the probability that the event happens before the other events, before some time horizon occurs, and also before another event has happened, so before treatment was initiated. For example, you might be interested in the risk of dying while patients are on the waiting list for a lung transplantation. Estimation quite straightforward, so competing risk approaches can be used here. Regarding the assumption that I worried about before, the same worry applies here. If we are estimating risk based on the development data where certain patients in certain time periods receive lung transplant, then the risk of dying estimated before that time period will only hold for new patients if similar strategies are used for lung transplantation. So this risk cannot inform the decision who should or who should not get that lung transplantation. If we would change our behavior in that way, that would sort of invalidate our predictions. We're sort of what's sometimes called stuck into some sort of a prediction paradox. If the predictions change our behavior, change our decisions, change our treatments, then that will invalidate our predictions because we will not be behaving according to how we develop the model anymore. And for that same reason, these risks cannot inform the right direction of treatment changes because it will be outside of the model, sort of. Again, it doesn't invalidate this approach. So using such a cumulative incidence approach can still be very useful. And I think, like this example also shows, it's often useful in cases where you cannot really choose what kind of treatment or when you want to start treatment. So in cases where there's sort of limited resources and some external process decides when you will receive that treatment. Then I come to the fourth and also the last of the prediction estimands that we will present here. And that is a hypothetical strategy. And here I'm presenting a hypothetical untreated strategy where we say we're interested in the risk the event of interest occurs before some time horizon. But now in a hypothetical world where treatment does not exist or where equivalently time to treatment is set to infinity using the sort of potential outcome notation with a superscript. This kind of risk can, for instance, be useful in a setting where we're interested in pregnancy rates. So that's the area where I also worked on together with David. So we might be interested in the risk of a natural pregnancy without IVF. So this is clearly a setting where you could more or less choose whether or not you would like to start a more invasive treatment or whether you want to stay in an untreated state. And you might be interested as one of the components informing your choice whether or not to start a treatment and what would happen if I wouldn't do it. So what is sort of my baseline risk, my untreated risk, or risk in this case more like chance of a pregnancy. And that might be one component you might want to know when you are considering starting a treatment. So actually this is the first out of these four that can be useful to inform a treatment decision. Preferably, of course, you would also want to know your risk if you would initiate the treatment. So maybe a hypothetical treated risk starting your treatment maybe directly at time 0 or at some other time point. So this is only one version, but you can think of other hypothetical strategies with a certain fixed time point where you start your treatment. And that would all be interesting and useful to know actually when you're deciding on starting treatment. What we're doing here is no longer factual prediction, so to say, in the sense that it doesn't reflect the actual data that we have observed, but we are trying to use the data that we observe to predict some outcomes under a different strategy. So in the data that we typically have at hand, we have a mixture of patients that are treated or not, or treated at different time points. And in this hypothetical strategy, we try to map that into a hypothetical world where there would have been a certain treatment strategy for all, which typically is not the case in the observed data. That's why we call these counterfactual predictions. The ability of doing that relies on strong assumptions, and that's directly also the downside of this strategy, is that the estimation is much more involved and relies really on strong assumptions. And actually, these are the same assumptions that are needed in case of being interested in the size of the effect of the treatment, so really in causal inference. And there we see sort of a mixture coming up from prediction and causal inference. So we're interested in prediction, and these X zeros can also be covariates which are not directly causally related, but like only associative. But we are very much interested in assessing the relationship between those predictors and the outcome in a certain world where a certain treatment strategy is used. And we are interested in having the real unconfounded effect of that treatment strategy. So here comes in a mixture of causal inference and prediction. Okay, so the estimation here is much more involved. I already said that. So what are things that you might expect? So if you're interested in untreated risk, hypothetical untreated strategy, then one approach might be to censor all your observations at the moment that they start treatment. For that being giving valid estimates, we need to have assumed that we have non-informative censoring conditional on then the covariance in the prediction model. Typically, that's too strong an assumption because there might also be time-varying covariates that have influenced decisions to start treatment, and we need to account for those too. For instance, using inverse probability censoring weights. Another approach might be to actually model the effect of treatment, so to actually estimate that from your observational data or maybe even from an external trial source. And then accounting for that treatment effect and set the value of the treatment to 0 when you make your prediction. This does not make it easier, it's just sort of another approach, but we are also still then need to be worried about how to get an unconfounded estimate of the treatment effect. If we would try to do that from our observational data, again, we typically need time-varying covariates and approaches like marginal structure models or other G-estimation approaches in order to estimate that. So that's really much more complicated, but I think it's also the only way where we can get estimates that can really inform our treatment decisions. So here are all 4 strategies sketched out a bit informally, so to say. So these are not strict DAGs, but just to once again show you that these strategies are really quite different. So I think you would, by my description, already expect like that you can expect different event rates, right? So if you only count death, or also count death and treatment as an event in the composite strategy, you will probably get more events. If you only count deaths before treatment was started, you will get less events, etc. But it's not only the event rate that changes, it's really actually also the size of the association between predictors and outcomes that will change, because we're looking at different associations. So if we are using the ignore treatment strategy, which is used most often, we are sort of looking at associations from 2 pathways. So one is sort of the direct one from predictor to event, and the other one is sort of a mediated one through the treatment path. So I don't know, a certain predictor such as age might be bad for you, so might lead to more events. But if all people are also treated, which improves their health again, that might cancel part of the real effect, and it might lead to maybe a much lower association combined when these 2 pathways are combined. In the composite world, of course, we're looking at sort of the joint effect. So how strongly does the predictor predict treatment? How strongly does it predict the event? In the while untreated strategy, we are looking only at the effect of predictors on event, but then limited to the time period where treatment was not yet initiated. So that is really competing risk setting where it's conditional on not yet having had this treatment. And in the hypothetical strategy, we're really interested only in the sort of the direct effects or association from the predictor to the event. In a setting where we choose a certain treatment strategy that might also impact the event, but which is no longer on the pathway from the predictor to event. So we're sort of trying to get rid of this arrow and evaluate only this pathway and no longer that one anymore. So you can really also not only expect your event rates, but also your effects of your predictions to become different in each of the strategies. Okay, so this is sort of the framework, quite general stated. So I would like to now make this more concrete in a data example. And this is an application in patients on dialysis. They started at baseline getting dialysis, and at some point in time, they might receive a kidney transplantation, and the event of interest here is death. This data set was a linked data set actually from a cohort study and a national registry. It contains a little bit more than 2,000 patients, all starting dialysis due to end-stage renal disease. 749 at some point received transplantation. A lot of patients died in the end. I think we are looking at a long period also here, 10-year follow-up. And a small part of them died after receiving the transplantation. What we did with this data was sort of make an illustration model. So a very simple prediction model based on only two baseline covariates, and that were age and the type of dialysis. And what we also used in the hypothetical strategy was these three time-varying covariates, comorbidity score, BMI, and a calcium blood value, which were estimated, I think it was every 6 months that people were seen and got updated values of these covariates. Okay, well, let's look at the 10-year mortality risk then for these patients according to each of the 4 strategies. So here we have the time since the start on dialysis, and here we have the mortality risk. And I'm picturing this for certain patients, so with certain covariate values, in particular age 50, and the type of dialysis was hemodialysis. If I would use the ignore treatment strategy, so meaning that I would count all deaths, whether they were before or after, with or without kidney transplantation, I would say that my mortality risk for this patient would be 43% in 10 years' time. If I would choose a different strategy and use composite strategies, so also count all transplantations as an event, I would be much, much higher. I would reach 95% risk. The while untreated strategy, I'm only counting the deaths happening before transplantation. And then I would expect this to be the lowest risk, which is the case in the end, but not so much here due to the proportional hazards assumptions that I'm making on different scales not truly being compatible here. So here I assume proportional hazards only for the event death, and here I'm only on the event death before transplantation, and here I'm assuming it for the event death also after transplantation. So that makes this sort of weird higher while untreated than ignore treatment. But in theory, you would expect the green to be the lowest. I would use the hypothetical strategy. So here I'm trying to estimate the mortality risk in absence of transplantation. Then I would get around 60% risk. And here we used 4 different ways of estimating it. So the censoring approach, the modeling approach, and then either only using the baseline covariates or also the time-varying covariates. And you can see that the differences between these approaches were not so large in this data set. But what you can see that these outcomes are, of course, very, very, very different according to the strategy that I'm using. And that is not so strange because these risks are really answering different questions. And that I would like to illustrate in sort of a fictive conversation between a patient and a doctor. So let's say that they are still now at baseline. So starting out with this dialysis, the doctor says, well, sorry, your disease has progressed further. So my advice would really be now to start you on hemodialysis. And patient might ask to their doctor, okay, what's my prognosis, doctor? One of the answers that the doctor could give is the following. So without kidney transplantation, if we wouldn't do that, then we expect about 60% of patients your age would die within the next 10 years. And then the doctor is using the hypothetical strategy. Okay, says the patient then, but what about my prognosis given that I may receive a transplantation? Well, doctor might answer, given the availability and the allocation of transplant like in recent years, if that doesn't change, then we expect about 43% of patients to die within the next 10 years. And then the doctor is using the ignore treatment strategy. Patient might be interested, okay, but what are my chances that I get a transplant in time? And then doctor might answer, okay, well, it depends. We need a matching donor and there is a waiting list. And if that works out sort of, again, the same as in the last past years, then we expect that you have about 34% chance of dying before getting a transplant. So that is the while untreated strategy that we use here. And then patient might still be interested, okay, but what are the chances that sort of everything goes well? I'm surviving and I'm still on dialysis in 10 years, time from now. And then the doctor might answer, okay, that's a 5% chance to still be alive and without transplant in 10 years' time. And then he's using the 1 - composite strategy. So this is to illustrate that the differences here are not really numerical differences, they are really interpretation differences. These kind of strategies answer different risk questions. And when we look at current practice, because this was just an illustration, this model was made just to illustrate this framework. If we look at current practice, so for instance, in the same area of kidney transplantation, a systematic review was performed of 60 prediction models. Aim of that original review was just to see what kind of methodology was used and whether the models performed well actually in an external data set. But we now looked at it from the perspective of these prediction estimands and looked at how they dealt actually with transplantation. We see very different approaches. So we saw that out of 16, 5 used a censoring approach. So they censored the observations at the moment people started transplantation. They did not, all of them, 5 did not refer to the assumptions underlying that or to the interpretation of their risk giving. They used this approach. 3 actually included death after transplantation as an outcome. So they sort of used the ignore treatment strategy. 3 actually excluded patients who received the transplantation, which I think is really conditioning on the future. So that really gives generalizability problems. And 5 did not write anything about what they did with these transplanted patients. So it's unclear what they were estimating. We saw similar things in a review on COVID-19 prediction models. So we took the first round of the Amazing Living Systematic Review by Highlands and colleagues. We looked at prediction models of patients who were hospitalized for COVID-19, and we scored what they reported as sort of the aims of their model. So these 4 points that we talked about before, the counseling, support and treatment decision of prioritizing patients, etc. And we looked at whether the estimation procedure that they used during development was actually in place to support that aim. And the results were quite disappointing. So we saw that out of these 34, 29 studies did not meet their aim. Majority of those claimed that their model could be used to support treatment decisions, but did not do anything with those treatments during model development. So you could say they used the ignore treatment strategy, but actually most of them didn't even mention what treatments were given to the patients. So no idea of knowing sort of how to deviate from that strategy or in what direction should you then be able to change behavior in order to improve health. These are some of the examples of the aims that were stated by them. So this is pretty much a random sample. There of course, were better performed and less well performed prediction models in these 34, but we saw these problems in all of them. So here we say, we aim to clarify high-risk factors so as to help clinicians choose better therapeutic strategies. Here's one saying, our decision support tools, they have strong potential to empower our providers to save lives by prioritizing critical care. Another one says, we've made a web tool, and then you can use our web tool, and for those patients with a relatively higher probability of death, more interventions could be adopted at an earlier stage by clinicians. These are, I think, quite common statements, and I see this in a lot of work on prediction models, and also have been guilty of this myself, writing about prediction models, that we try to motivate our model or our methodology sometimes, like saying, okay, prediction is important because we can help make better decisions. But I also think this is most of the times really unfounded. None of these papers listed here really give information that can drive treatment decisions in a certain direction. Okay, they might indicate people are at high risk, but then at high risk under current strategy, sometimes not even saying what kind of strategy that was, but also totally not clear how to change from that strategy in order to improve something. That's not what these models can do. So that's a bit of my negative message to you today. And I'm also happy, of course, to discuss with you if you have different views or more optimistic views on what models can do. But my conclusion from this work is that we have these different strategies. Most of them, I think all of them, are useful to counsel patients. Most of them can also, in some sense, be useful in selecting high-risk patients to maybe evaluate treatments in. But very few of them are actually able to inform individual treatment decisions. And there, I think you really need a hypothetical strategy. You need to be able to assess risks under a certain, either no or all or early or late or whatever, a certain treatment strategy in order to have some information to guide your decision. And the same holds, I think, for a situation where we want to prioritize patients. I think you need a little bit less there than in this case. So here, I think you really need good view on the absolute risks. So what level of risk are we at, and how does that weigh against possible side effects or costs or burden? In prioritizing patients, I think you sort of only need the ranking. If you say you have a limited number of treatments and you want to give them to those who need it most, you may only need the ranking. But also for the ranking, because we saw that these associations between predictors and events change in each of the strategies. Also there, you need to estimate hypothetical risk or risk under hypothetical strategies. So that's my main message, my conclusion. I think the meaning of the predictions that we present to our patients should be crystal clear. And they need to be aligned to the intended use of the prediction model. And currently, I see in literature there's a big separation between those. So there's a lot of words on what prediction models might help out with, but when the actual prediction is being done, this is sort of set aside and not paid attention to. And in general, the factual predictions, so these are the first three strategies, can be very useful. They can counsel patients. They can also indicate high-risk groups. But for making treatment decisions, we need counterfactual predictions. Some of the ongoing projects that we are working on currently, first is one interested with Ilaria Prosepa. I'm working on how large the differences you can expect between these different strategies. So the numerical illustration that I gave on the transplantation data really shows very big differences. Some other work, for instance, by Matthew Sperrin and by Robin Pahiveshnia in the cardiovascular risk prediction have shown quite small differences between different strategies. So we are investigating now what are actually the driving components of when would you expect larger effect of these different strategies. Second very interesting topic that we're working on is how to actually validate counterfactual predictions. That is also a big challenge in counterfactual prediction. If you are trying to see how well your model works in terms of calibration, discrimination, etc., but also in your new external out of sample data, you have a mixture of patients with and without treatments, then that is not so clear how to do that. And the third project that I'm working on is what kind of impact you may expect of informative censoring. So there you have the sort of the four approaches that we use that actually showed very similar results. I've seen that more often, and I'm interested here in to see how strong does the informativeness need to be in order to have a big impact of informative censoring. Okay, so here are some of the references. This is our 2020 paper, giving most of the details, also topic of this presentation, the addendum guideline, some very clear papers from Matthew Sperrin and from Pioesnia, and an earlier paper also on the transplantation topic. So I hope you have questions and maybe even different views and maybe more positive views on the prediction possibilities. I would be very interested to hear. Thank you.
Thank you, Nan. Yes, you've certainly done the job of shaking us all up a bit, I think. It was actually quite nice to have this. We had a talk back in September about basic estimands, and I certainly felt shooken up then. So, but yes, to move into predictimand is yes another sphere altogether, isn't it, for us? I'm just waiting to see if there are any questions in the chat. Don't see anything in the chat. Oh, hang on. Yeah, Graham's got his hand up. Graham, do you want to give you a question or comment? Graham's gone very quiet. Are you there, Graham?
I am, yeah. Sorry about that. No, and thanks for the talk. Every time I listen to these talks, I realise that I know less and less, not more and more. The question I was going to ask, you actually asked it yourself as a future project around about how to validate counterfactual predictions. So to build on that, the example that you gave, what data set, what would it look like? What would you need in the sort of the kidney example you needed to validate the counterfactual predictions?
Yeah, so we're currently actively working on that, and it's sort of challenged with the same challenges as when developing counterfactual risks. So you have a mixture of patients with different treatment initiation or no treatment initiation, and you want to know how your counterfactual risk prediction model performs under a certain treatment strategy, which may be different from what was observed in most of the patients. So I think what we're currently working on is sort of two approaches. So one is similar to the censoring and maybe inverse probability of censoring weights approach. So you might say that I'm only validating the observation period up until when patients start deviating from that particular strategy that I'm interested in. And then you might be able to look at things like calibration discrimination up until that time point, and then, of course, combined over different periods of time when each observation in your validation set was compliant to your strategy. So that's one approach. And the other approach that we're looking at is to sort of take the observations as leading and saying, okay, my prediction model was intended for one certain strategy, but I can also look at whether it is capable of predicting the particular strategies that are observed in my validation data. And if it would be capable of doing sort of that larger task of predicting well a mixture of strategies, then I might imply from that it's also capable of doing a certain strategy that is one of the strategies, part of that big group of strategies that I'm evaluating. And then you would need a counterfactual prediction model that is not only able to predict under one strategy, but under different strategies that are all observed in your validation data. So that might, for instance, be possible if you were to use a marginal structure model sort of approach in your development setting, then that would allow you to predict under different strategies, and then you could do those that are observed in your validation data.
Okay, because I don't see another hand, Lorna, so I'm just going to follow up with another question. Because I'm interested, you mentioned marginal structural models there, because when I was looking at, when you had the four diagrams up on the different strategies, I know we weren't supposed to interpret them as DAGs, but I couldn't help myself. And the last one looked like a clinical trial to me. So I was wondering, would there be a way to validate your hypothetical strategies using clinical trial data? Or is there some way of, could your counterfactual predictions be mapped onto, like maybe a sort of emulated trial from observational data to see if you got roughly the same treatment effects, for example? I know that's not quite the same as calibration and prediction, but do you have any thoughts on that?
Yeah, I think you could. And I think actually, well, what we're interested in this hypothetical strategy is sort of one arm of a clinical trial. So we're typically interested in estimating the risk under a certain treatment strategy, and that might be evaluated in an experiment if you actually allocate people to that certain strategy. If you would have that kind of data, that would be perfect to validate it in that. Only I think typically you don't have that at your disposal. So then indeed you are using observational data to sort of emulate that kind of situation. And that's also what we're trying to do. For instance, with the censoring approach, where we censor and reweight at the moment that they start deviating from that hypothetical trial, in order, in an attempt to emulate that trial arm from our observational data.
Okay. I'll stop talking now. Let somebody else ask the question.
There's a question here from Bernard. I've lost it. Would you envisage studies involving experimental designs, e.g. where drug doses need to be chosen? Ben from Glasgow.
Okay, I'm not sure. Does this still relate to the validation question? So an experimental study to validate the counterfactual predictions?
Ben, are you able to ask the question directly?
Can you hear me?
Yes. Good.
Sorry, I was speculating. I realised I wasn't taking precise details of your study into account.
Right. Okay. So I was interested in your sort of one of your final boxes where you were sort of had smiley faces and not so much boxes, but later on, yeah. And one of the criteria, or the last two criteria, was that most of the strategies didn't really take into account how to inform individual treatment. But then the last one is the priorities, to prioritize limited resources. And I suppose that, again, I'm sort of thinking about a trial setting. We normally don't actually want to look at individuals. We're looking at something as a whole. But actually we are quite interested in being able to sort of prioritize resources to some extent. I don't know quite what my question is, but
you mean more on a group level, on a
yes,
in a policy level?
Yeah.
So in risk prediction, typically we are interested in individual patients, and so the prioritization here, what I was thinking of was indeed more choosing between patients. So for instance, on a waiting list for a lung transplantation, if one becomes available, who to give it to, or maybe in the current discussions on ICU availability for COVID patients, like if we are in code black, then who gets that bed? But maybe what you are thinking about more is if you are thinking about like admitting drugs to the market or something. So which are the most effective and cost-effective ones that you would want to have insured or want to put in your guidelines. So for that situation, I think typically you're more at a group level, maybe indeed stratifying for certain subgroups that it might be more effective or more cost effective to do it. But I think those decisions are not really based on like prediction models for individuals. More to say like maybe subgroup analysis, a kind of approaches from trials, or
but we're probably still still do need to take into account estimands rather than predictimands in that setting as well, because we do get treatment switching and all sorts of funny things going on. So
yeah, certainly.
Now I see that Graham's got his hand up, but I also see that John, you've put your camera on. Have you got a question? Can't hear you. Still can't hear you. No sound. Okay, I'll go to Graham. Graham, you've got your hand up. Are you going to come in on that?
No, I don't have a question.
I couldn't wait for John. It looked like John was just about to press his button there, so John doesn't have a question.
Ik heb geen vraagjes. I was just checking. I just realized my camera, my microphone was in mute, and rather, I thought it was my microphone itself wasn't working.
Yeah. So Nan, this slide's interesting because I know this research is all fairly brand new. But do we know what patients want from risk prediction models? I would imagine they would want counselling, but also they really would want to know about how a risk model could inform their individual treatment selections. So a two-pronged question.
Might change as
yeah. I mean, do we know what patients want? And if so, I think the title of your talk probably does hold that the majority of prediction models out there will be next to useless against the four meeting the criteria that patients might want of the four that you've laid out before. So sort of two questions in one there. Yeah.
So I think the counseling is always important, and I haven't asked patients, or I didn't do any research into direct preference elicitation in patients. But what I can imagine is that, like, sort of being prepared for what will happen, so sort of knowing what's to come, and also knowing what's to come under current treatment availability or current treatment strategies is very important to patients, and most models can support that. Apart from that, if they are sort of at the verge of deciding whether or not to start a treatment, I think the information that they would need to be provided with is their risk if they do it and their risk if they don't do it. And that's really, only capable of being provided by prediction models that choose to model things under a certain treatment strategy. And that's typically not what we are doing. And I think that's really a shortcoming. That the predictions that we give and that can be given from all these nice web apps that are out there, they are all developed under a certain already existing strategy, and they do not really help in choosing another strategy.
Yeah, and that's true of whether it's a simple Cox model or some sort of fancy AI, I would imagine.
Yeah, I think the troubles hold for all of them. What I mainly focus here on is treatment start after baseline, but there's also some work already for treatments that are already given at baseline, where also sometimes it's not taken into account. But how to deal with that then is a bit sort of easier. You could use that as one of the predictors, whether or not you're already on that treatment, but it's also not often done explicitly.
Okay, thanks.
Okay, I think if there are more questions, please continue to send them to us. But I'm conscious of time now, and we've got to our AGM to follow. So I know the committee need to probably have a bit of a break. I, for one, my little watch has gone buzz, buzz, buzz. You've not moved for a long time, so I'm going to go and grab myself another cup of tea and run down the stairs and come back up. People are welcome to stay on for our AGM if you'd like to, but unless you're on the committee, you have to stay mute. So that's the condition, but you are certainly welcome to. It just leaves me really to wrap up this particular session to say thank you ever so much to Nan. As I say, you've shaken us all up, and as Graham said, yeah, I know, I thought I was getting there, but I've actually know less and less. But complete, yeah, we've got a good hook on you now, and no doubt we can call you back at some stage to find out about the next stage of developments. I'm certainly keen to hear where you go with that. So yeah, without much to do, and I know it's really difficult to clap when you're all online, but thank you very much. And,
thank you for having me.